Good morning, everybody. Very warm welcome to all of you to this pre-COMy symposium. So the Congress will open officially in around 90 minutes or so, but this early morning symposium supported by Springer has become a tradition, and we're very fortunate and happy having you with us this morning. So you will see I'll be joined really by a terrific and highly distinguished faculty, namely Dr. Suzanne Lentzsch from Columbia University in New York, Dr. Rakesh Popat from University College Hospital in London, and last but not least, Dr. Saad Usmani from Memorial Sloan Kettering, New York. So New York is well represented, but this is just by pure chance. Yeah, my disclosure, sorry, I don't want to forget this. Okay, what are our learning objectives for this morning? And this is CME-accredited Sympo supported by Springer. So Springer, these are the guys who do the journals, you know, they don't manufacture drugs. This is Nature Medicine, Leukemia, BMT, they have hundreds of them. So very nice academic spirit. So our goal this morning is to try at least to explain the different BCMA targeting strategies for patients with myeloma. You know very well that targeting BCMA has become a big thing in myeloma, whether we're talking about bispecific antibodies, whether we're talking about CAR T cells, whether we're talking about antibody drug conjugates, and there will be more and more, I think, therapeutic tools where BCMA is involved. And then we'll evaluate the latest clinical data available for the different therapies targeting BCMA and their implications for clinical practice. And our third learning objective for today is to assess the challenges and, of course, the remaining or unmet needs for the future of myeloma therapy. And by the way, I'd like to extend also my warm welcome to all our digital or virtual audience. There are already several thousands of people connected. So thank you all for joining. I'm trying to speak to the camera and say hello. So our agenda today, after this introduction, we'll start with Dr. Usmani discussing the bispecific antibodies targeting BCMA, and there are a few of them being approved. Dr. Popat will discuss the antibody drug conjugates, and especially belantamab, where you've seen some really fantastic two large positive trials being released recently. And of course, we can't escape the talk about CAR T cells, because obviously cellular therapy is really extremely important. It's a highly interactive activity, so you could see on your chair, your seat, the different QR codes where you can join the meeting polling. You can also interact with us and send your questions. Obviously, personally, I like to see you on the microphone in the room, you know, and standing up and discussing. But definitely, you can use these QR codes, and obviously, for the live broadcast audience, polling on the right-hand side of the screen next to the video. As I said, it is CME-accredited, so you can claim your CME points, and I think most of us would need these points at some point. So please don't hesitate to claim these EBA point according to the usual procedure. And of course, I'd like to have a special thank to the funding organism. So this program is made possible thanks to an educational grant received from GlaxoSmithKline. Of course, if you want to get CME points, there will be some assessment questions, and this is where I need your cooperation and that you become familiar with the QR code. Let me start with the pre-assessment. Obviously, I usually try to give the right answer, but today I'll be very tough. I won't give you the right answer immediately. So we'll give it later at the end. So question number one, which of the following options represent a potential advantage, only one, of using bispecifics to target BCMA and relapse refractory multiple myeloma treatment? This is not me. A, unpredictable incidence of neurotoxicity and CRS. B, limited compatibility with other treatment mechanisms or mechanism of action. C, off-the-shelf availability in case of a rapidly progressing disease. And D, logistic challenges for community management during initial patient monitoring. So please vote, because this is mandatory if you want to get your CME point. Should we give them 20 seconds to do it, guys, with your iPhone, iPad, smartphone, whatever phone, smart thing? Are you there? Can I ask the technical team if they're happy? Everything is going well? Thank you. Question number two. Which of the following options is false? So we have four. One of them is wrong. Belantamab targets BCMA. Obviously, you heard my introduction. Belantamab is an antibody-drug conjugate indicated in relapsed refractory multiple myeloma. C, belantamab is currently only indicated in the frontline setting. And D, a step-up dosing is part of the administration schedule of belantamab. A little bit tricky, some of these claims. Please vote. And of course, those who got it right will have some prizes, guys, because this is the 10th anniversary of COMy, so there will be some celebrations there. Question number three, and this is the last one, don't worry. Which of the following statements is correct? So we need the right one. So you have four, three are theoretically wrong. The toxicity of CAR T cells is difficult to manage in the setting of myeloma. A little bit tricky as wording, but nevertheless. Bispecific antibodies can only be developed against BCMA. And the optimal sequence of the different immune therapies in myeloma is yet to be established. Patient can never receive bispecifics or antibody-drug conjugates after CAR T cells in myeloma. Well, you know, guys, in general, only or never are rarely true in medicine, but this is my personal opinion. Anyway, please vote, guys. And again, welcome to all those guys joining us. I see more people joining in the virtual. It's already afternoon in Asia, and this meeting is being translated, by the way, into Chinese, Spanish, Portuguese, and Russian. I guess South America will join a little bit around noon because they're still sleeping now. So without any further ado, I'd like to welcome Dr. Usmani, who doesn't need a long introduction. Saad has been a strong contributor to the myeloma field, and he will discuss some of the recent bispecific antibodies data, and he contributed to some of the registration trials in this field. Welcome, Saad, and thank you all again, and please don't forget to interact with us. Thank
you. Good morning, everyone. Thank you so much, Mohamad, and to the COMy chairpersons for inviting me for this session. I think this is a hot topic. There's a lot of new data that's coming out. My colleagues will talk about this as well. I'm going to focus on the anti-BCMA bispecific antibodies, and these are my disclosures. And oops. So in terms of, can we go back one slide, please? Here we go. So I'm going to talk about the mechanism of action for bispecific antibodies, just as a refresher. Then go through the clinical trial data with the existing BCMA-directed bispecific antibodies. But more importantly, I'll talk more about what we've learned in the real world after the approvals of the BCMA bispecifics. Some of the lessons learned and others that we still have to learn, and then cover the practical considerations in giving bispecifics and then wrap things up. So in terms of the mechanism of action, it's fairly straightforward. The concept of the bispecific antibody or the T-cell engager or the BiTE, whatever we want to call them, is essentially recognizing the surface marker on the cancer cell with one part of the structure and recognizing an immune cell, in this case being the T cell, with the other part of that structure. And depending on the structure, the bispecific can be shaped in many different ways. And so there are many different platforms, and the half-life, the affinity for the target, the affinity for the immune cell, surface marker, determines the efficacy, the safety profile, how the drug is given. So there are many different constructs of bispecifics, but the function is very similar. And now we are not going to be discussing this, but there are tri-specific constructs kind of following that same pattern. With regards to the clinical trial data, I'll be talking about some of what we've learned with teclistamab, which was the first EMA FDA-approved bispecific antibody in multiple myeloma back in 2022, so almost 2 years ago. So while we have clinical trial data in the phase 1-2 setting, and now new data emerging potentially in earlier lines of treatment, I think most of our data is in the relapse refractory single-arm studies. We actually have 2 BCMA-directed bispecifics that are currently FDA approved, teclistamab and elranatamab. But if you look at this summary slide, which looks at dosing of the therapies and the route of administration, you'll find that there are differences. And this is really based on that initial slide that I shared with you of how these constructs are structured in a different way. But what's important to note in this slide is the activity level. If you go back just a decade ago, when we were just getting second-generation proteasome inhibitors and immunomodulatory drugs and some of the naked monoclonal antibodies, the responses we would see were somewhere around 20 to 30%. And now across the board, we see 60% plus responses with the different BCMA bispecific antibodies. And the median PFS with teclistamab is perhaps the most mature, and it's a little under a year, which is again quite impressive, because the median PFS, when we used to think about PI mid-refractory myeloma, used to be around 3 or 4 months. So seeing these results is really very encouraging. However, we also have certain challenges. We know that targeting BCMA with bispecifics leads to infection risk as we continue therapies. And this signal is similar across various BCMA bispecifics. Even if we account for the fact that these are relapsed refractory myeloma patients, I think the continuous therapy model here does increase the infection risk as we go further down. And this is where I think we're learning still. With the Majestic 1 clinical trial as an example, the initial dosing of teclistamab was subcutaneous weekly. But in patients who had achieved a plateau in their depth of response, those patients were allowed to get Q2 or Q4 week dosing. And so that new onset of grade 3 or higher infection does decline as you change that schedule for patients. And I think that's a very important lesson. And this is something that we're learning. Can we actually employ that method, that approach across the board from patients from very early on? And that experience is actually helping shape other BCMA bispecifics in terms of how we're going to be dosing them and giving them to our patients. Another very important thing is that not every myeloma patient in the relapse setting on those trials, despite the elegant mechanism of action, responds to treatment. And there are several different reasons for that. It's quite possible that it has to do with the degree of affinity for the T cell or the inherent dysfunction that patients have. It could be tumor specific in terms of antigen expression or diminished or loss of the antigen on the surface of the myeloma cell. And then there are also bispecific characteristics and the microenvironment factors that could be playing a role. So this is where I think there are combinations that can be rationally utilized, and there are clinical trials right now exploring each of these. So combining the BCMA-directed bispecifics with anti-C38 monoclonal antibody strategies or checkpoint inhibition or cell mods to see if you can improve the depth of response and reverse some of those inherent issues of resistance. As an example, I'm just sharing this, with the telquitamab experience. So TRIM2, the telquitamab is a different, bispecific. It targets GPRC5D. But, the experiment is being done to see if you can actually, get away from that other mechanism of action of resistance and in terms of the Treg activity in myeloma. More importantly, the bispecifics are now being combined, to see if it is a target issue or not. And this particular experiment was very elegant. So Redirect 1 clinical trial looked at combining teclistamab with telquitamab, showing response rates of 98%, especially in extramedullary myeloma. And why is that important? If we thought that it was just due to dysfunctional T cells, we should not be seeing these responses. So it's an antigen issue as well. This is where I think rationally combining the bispecifics either with different targets or with other mechanisms of actions makes sense. So the other important aspect of this Redirect trial where we are combining different bispecifics is the fact that for extramedullary myeloma, there appears to be a strong signal. So will we need to combine bispecifics for all myeloma patients? Probably we're going to be picking treatments for certain subsets of patients where it makes sense. And I think extramedullary disease is somewhere that we all can agree that there is good activity and we should be thinking about different strategies. Now, let me talk about real-world data in multiple myeloma. I think most of this data is with teclistamab just because, it's been around for almost 2 years. Our German colleagues looked at their experience in 123 patients who got teclistamab, compared it to the Majestic-1 clinical trial, and showed that, their own real-world experience, many of those patients could not have gone on the clinical trial because of inclusion-exclusion criteria. However, if you look at, prior BCMA exposure, prior, presence or absence of high-risk karyotypic abnormalities or extramedullary myeloma, we're still not getting the same bang for the buck. So the point, being that even with this experience and good activity, I think that there are opportunities in which we can improve the bispecific, BCMA bispecific antibody function by rational, clinical trial combination designs. And going back to this, slide, how do we study these mechanisms of resistance in real time? How do we study the T cell dysfunction? Well, If you have a peripheral blood flow cytometry-based methodology in which you can recognize patients who have certain features, you may actually think ahead of time and employ different strategies for those patients. If you are able to identify antigen loss or downregulation, maybe you should be thinking about another antigen, to be targeting the bispecific. If there are certain disease burden issues such as increased soluble BCMA, again, you can think about cytoreduction with other therapies for those patients. So I want to share some of the work of my fellow Ross Firestone. It's already published in Blood Advances as well as the Blood Journal just as of last week, where we looked at peripheral blood flow cytometry, patterns of T cell activity and dysfunction, where a priori you can see patterns of regulatory T cells being active, correlating with teclistamab not working in patients, whereas patients who had CD8 positive T cell, effector T cells, activity signature, those are the patients where you are going to see teclistamab activity. And I would bet that we will find very similar kind of patterns with other BCMA bispecifics as well, because this really speaks to the patient, pattern. And then the other important thing, the loss of BCMA antigen. We had previously thought, from the early data that was presented from the Calgary group, that this may happen with bispecifics or CARs, but it can also happen with antibody-drug conjugates. So this paper from my fellow just came out in Blood last week, and I would bring this up during the discussion. This would be very important because we didn't think that this could happen with antibody-drug conjugates. The other important practical lesson that we are learning is, yes, you can cycle different T cell redirecting therapies in patients, and the patterns of CRS are going to be different. So in patients who have had prior CAR-T or bispecifics, you may not get the same cytokine release syndrome, but that does not mean that the patients will not have a response to therapy. So that's, Issam Hamade from, one of our pharmacists had published this, recently in Blood Advances. I also want to share our outpatient bispecific administration experience. This is something that we started to do in MSK within a few months of getting the FDA approval, but we did it in a stepwise fashion to make sure that the CRS signal that was seen in the clinical trials, that we're not seeing something different in the real world population. And, and very interestingly, there was a paper that was presented at ASH looking at the real world characteristics of patients getting teclistamab, looking at an all pairs claim-based, database. And what was very interesting in this particular experience, if you look at, the graph on the right side, the bar graph, over time, patients who were getting teclistamab and being admitted for that initial, step-up dosing period, as physicians and hospitals gain experience, the time patients were in the hospital continued to decline. So pretty soon, I do feel that many of our community colleagues would be able to give these bispecifics all in the outpatient setting and manage CRS effectively. Why? Because in the real world, if you look at the CRS being reported, both the percentage as well as the intensity is lower than what is being seen in clinical trials. So with that, I want to end with a few, practical considerations, for bispecifics. They're off the shelf. The CRS appears to be lower than what we see with CAR T cell therapy. Neurotoxicity, is, kind of unheard of. It's very, very low. It's, in single digit percentages. But the cons are not every patient responds to bispecifics. So we need to figure out how best to, give these in combination with either other bispecifics or other mechanisms of actions. To mitigate the infection risk, giving, VZV and PJP prophylaxis. Hypogammaglobulinemia needs to be managed with IVIG administration. Those things need to be, worked out. And again, from the practical standpoint, in our program, we try to give less frequent dosing of bispecifics once patients have plateaued, because with BCMA bispecifics, we always worry about the infection risk. And outpatient step-up dosing is something that we have started to employ for specific patients. Good performance status, living within 1 hour of MSKCC, and that's by not by distance, but just drivability, as Dr. Lentzsch will also tell you. And we give dexamethasone to those patients to take home. If they develop any CRS signs such as fevers, we give dexamethasone and move on. So hot off the press, the International Myeloma Working Group just published these guidelines. So for all of you who are interested, you can go and read these recommendations. Happy to chat about this later as well. So, we have come a long way, with targeting BCMA bispecifics. We're learning a lot more. I think, one major advantage of the bispecifics is the off-the-shelf accessibility issue. And I think CAR-T equitable access remains an issue. And this is where I think bispecifics will be super important. Thank you so much. I'll hand things back to Dr. Mohty.
Thank you very much, Saad, for really very beautiful talk, very comprehensive. Unless there is a burning question, I suggest to leave the discussion until the end, and it would be more appropriate to have a discussion on the global picture of the BCMA targeting drugs. So now the next topic is going to be about the anti-BCMA antibody drug conjugates. And we have the great pleasure to have Dr. Rakesh Popat from the UK. And you will see he has really an incredible experience in the use of antibody drug conjugates targeting BCMA, and they proved, you will see, to be extremely valuable for the management of patient. And I think there are still a few seats here. Otherwise, we have the overflow rooms outside. So thank you, Rakesh, and welcome.
Good morning, everyone. And it's a great pleasure to be here in Paris. And I'm so pleased that we've got a packed room. It's fantastic to see you all bright and early at the beginning of this Congress. It's my great pleasure to talk about antibody drug conjugates in multiple myeloma. I think many of you will be aware that this has been a rapidly changing area in the world of multiple myeloma, and there's new data coming out which I think will change where we're going to. My disclosures are shown here. So the development of antibody drug conjugates, specifically in multiple myeloma, has been hugely challenging. Those of you who work with other hematological malignancies will be aware that some are indeed approved and used on a regular basis in other types of blood cancer, but myeloma hasn't been so straightforward. What I've done is I've listed in the table behind me a number of different drugs that have been developed for multiple myeloma. And on the right-hand side, you will see what I think the current status is. And it's actually a little bit depressing, because what you see is that many studies have been completed, but many studies have been discontinued, and many products, unfortunately, haven't moved to further or later phases of their development. And indeed, when you look across the entire of this table, only one drug, belantamab, has actually been able to move forward to phase 3 clinical trials. Now, it's not just antibody drug conjugates that have been challenging in multiple myeloma. We've also had challenges with immunotoxins. And immunotoxins are basically antibodies which are fused to immune conjugates. And so some may think it's very similar to an ADC. We saw some very interesting data previously reported with modocafusp alpha, which is TAC573, a CD38 immunocytokine, which was reported at ASH. And you can see on the slide that actually the results were quite encouraging. On the right-hand side was a similar monoclonal antibody targeting CD38 with a different immunocytokine. But again, you can see here that this has some significant toxicities associated. And as a consequence, neither of these two antibodies are being moved forward. And this has been released in the public domain. So it just, I think, tells you how challenging this development area has been. The question is, why is it so challenging? And what we think that these should be very promising drugs, so why is it difficult? Well, I think antibody-drug conjugates in general are challenging molecules to design and to deliver for patients. It's really a balance between efficacy and toxicity. On the slide behind me, you can see the structure of an ADC. It's loosely based around an antibody, which is typically a humanized or a human monoclonal antibody, which is designed to target an antigen of your choice. And you do have the Fc region, but the key component of this is in red. You have the linker and the payload in green. Now, these are all variables that you can change according to the antibody structure that you have. And we have a number of different types of linkers. We have reversible, cleavable, and uncleavable linkers, which are stable or can be cleaved depending on where it is in the blood system. And we have a variety of different payloads. And these payloads are different chemical structures. Some are permeable within the cell membrane, some are retained within the cell, and others have better tissue penetration. So what you can see is that it's a very complex picture, and you need to have the right balance between the payload, the linker, and the binding of the antibody, as well as the specificity of the antibody to result in the overall toxicity-efficacy balance. And it's not easy to get that right, and I think a number of different drugs have struggled with that. We also have the second problem, which is off-target toxicity, and unfortunately many ADCs have been plagued with off-target toxicity, which has led to the withdrawal of such drugs. But the good news is that technology continues to improve. We only have CAR T-cells and bispecifics now because of the advancements in technologies, and we're also seeing significant advantages in the linker regions and the payloads. And so I really do think that this kind of slightly depressing picture with ADCs is going to start changing, and we're going to start seeing some new drugs coming through very much in the future. So do watch this space. And the reason why these are coming through is because of the success of this drug. So this is belantamab mafodotin, which is the first antibody-drug conjugate to be licensed for multiple myeloma. And it was licensed on the basis of the DREAM2 study, which the results are summarized on the slide behind me. This was a phase 2 study which was delivered for patients with triple-class refractory multiple myeloma. Now, this was one of the very first BCMA-targeted treatments to be developed, and so this came along before the era of bispecifics and CAR T-cell therapy, and this population of patients really had very little alternative treatments to be delivered. So as you can see, in this DREAM2 study, the response rate was about 32% and the PFS was just 2.8 months. But we're already seeing a signal in terms of efficacy here, because if you look at the durability of the response, so this is the durability of patients who achieve a PR or greater, then it is already up at 12 months. Now, Saad has already pointed out that we are expecting for this population a progression-free survival of just 3 months, and we're expecting survival of between 6 and 12 months. And so it's very heartening to see a median overall survival being shown in the region of 15 months. Now, whilst the response rate is 30%, half of those people who respond get a VGPR or greater. So we're already seeing that half of the people who respond are having a survival of 30 months. So clearly there is a signal that we're seeing here, but we just need to understand that a little bit better. On the right-hand side, you can see the main toxicity, which is that of corneal abnormalities and the microcyst formation that you can see on slit lamp examination of the cornea. So the pivotal study was the DREAM3 clinical trial, and this was really meant to be a confirmation study for the regulators to demonstrate its efficacy compared to standard of care, pomalidomide and dexamethasone. And what I've shown you on this slide is the more updated data, which was 10 months following the initial data cut, which was submitted to the FDA. As you can see on the left-hand side, the primary endpoint was not met, but nevertheless, there was a numerical improvement in progression-free survival of belantamab at just over 11 months compared to about 7 months for pomalidomide and dexamethasone. But what you see here is this interesting crossover where there's this very rapid drop-off in progression-free survival very early on, which you don't see with pomalidomide. And those of you who are familiar with pomalidomide will know that these patients just kind of chug along. They get these minor responses and they kind of maintain it, and they don't always achieve a deep response, but they are maintained very nicely with this immunomodulatory effect that we see with these types of drugs. Belantamab is an antibody, so it's got to bind to begin with in order to have its effect. And my understanding is that if you don't get this binding, whether it's because of tissue penetration, whether it's because of high levels of soluble BCMA, which may be sinking the antibody, then you're not going to get an effect. So you see this very high drop-off. This drop-off is not just akin to ADCs. You see this with bispecific antibodies as well. So if you look closely at that Kaplan-Meier plot, you see this very early tail drop-off because of a lack of binding in my estimation. On the right-hand side, you can see that, again, if patients respond, they respond extremely well with a superior durability of response. In terms of toxicity profile, well, we know that ocular toxicity is seen, and you can see the sprinkling of blurring of vision, dry eyes, photophobia, and various different adverse events that you see across with belantamab mafodotin. So, unfortunately, it was withdrawn by the FDA and the EMA on the basis of that clinical trial, and so some of you may not have so much experience of using that drug, but nevertheless, 2 different phase 3 clinical trials have been moving forward. And these are really looking at the combinations, because we all know that single agent drugs really isn't the way forward in multiple myeloma. We do need to be attacking the clone in various different ways. So the first phase 3 clinical trial that was launched was the DREAM7 study. And the DREAM7 study was a prospective phase 3 clinical trial for patients with relapsed multiple myeloma who have received at least 1 or more prior lines of therapy. They were excluded if they had a previous BCMA-targeted treatment, and they were also importantly excluded if they were refractory to or intolerant to either daratumumab or bortezomib. Now, the reason why this is important, because the control arm of this study is daratumumab, bortezomib, and dexamethasone, which is incidentally the standard of care for patients in the UK with relapsed refractory multiple myeloma. And in this, patients receive daratumumab in the standard fashion, and just remembering that bortezomib is delivered in the licensed format, which is bi-weekly, for the first 8 cycles, and then stops afterwards, and then from cycles 9 thereafter, daratumumab is given as monotherapy in a more of a maintenance fashion. The experimental arm you can see here is belantamab, which is given as per DREAM3, which is 2.5 milligrams per kilogram on a Q3 weekly dosing, in combination with bortezomib, again the bi-weekly dosing regimen that you're all familiar with. And the bortezomib is stopping after 8 cycles, and you get, again, a more of a maintenance phase of belantamab monotherapy delivered. Again, the intended schedule is 2.5 milligrams per kilogram given on a 3-weekly basis. Treatment is continued until disease progression or intolerance, and the key primary endpoint you can see here is progression-free survival. So what was the demographics of this population? Well, the first thing to see is that this was a large global study, 243 patients enrolled into the experimental arm, 251 patients enrolled into the control arm. You can see that the majority of patients were enrolled at 1 prior line of therapy, 51%, and 50 patients accordingly. But it's also important to note that 50% of patients 50% of patients had prior lenalidomide exposure, which you can see here, and about a third of patients were lenalidomide refractory. And this is well balanced across both groups. And this kind of speaks to when this study was running, because of course this study was running a few years behind. Typically, phase 3 clinical trials are enrolled in Europe, more so than the US, as most of you will be aware. And so many countries didn't have access to lenalidomide as frontline therapy at that stage. Certainly in the UK, for transplant-eligible patients, we were giving DVTD and continue to give DVTD. So that, I think, accounts for the slightly lower lenalidomide exposures, as you would expect, compared to a trial that was starting now compared to when it was done before. And I'd also like to point out that the prior daratumumab exposure is low. okay, and was also well balanced against both groups. So what you're not seeing is a daratumumab retreat study for DVD, which is one of the concerns when you have daratumumab given in a relapse setting. It is not a retreat study because the majority of patients did not indeed receive daratumumab. So what were the results? So this is the primary endpoint, and this was results. This was reported at the ASCO plenary series by Maravi Mateus earlier this year, and an update will be being presented in the next couple of weeks at ASCO again. You can see that the primary endpoint here was met with a superior progression-free survival for belantamab, bortezomib, dexamethasone, shown in the top curve. Sorry, could we go back? Hold on. Here with I think, a very excellent progression-free survival of 36.6 months compared to 13.4 months with the control arm. And of course, what you're not seeing here is that crossover that you saw with the DREAMM-3 clinical trial. You're seeing a very clear improvement in progression-free survival. Now, some of you may be wondering that actually that median PFS for DVD is slightly lower than you would see in the CASTOR trial that was reported. And what I'd like to remind you is in the CASTOR trial, very few patients had lenalidomide. It was done in the pre-area. So I think what you're really seeing is the effect of lenalidomide pre-exposure and lenalidomide refractory patients. And actually, if you look at the subgroup analysis and the real-world data that's coming out with DVD, it's actually spot on what you'd expect to see performing in that study. This is the interim overall survival results, and of course this is slightly early in terms of a data readout, but clearly we're seeing trends towards an improvement in overall survival, and actually if you look at the p-value, it's already significant just at this early time point. So how about safety? What you're seeing, and I'd just like to focus, is the hematological toxicity, because we do have overlapping toxicities with belantamab, with thrombocytopenia, and bortezomib. So as you'd expect to see, there is a higher level of thrombocytopenia with Bela-VD compared to Dara-VD. And it's important because these patients remain on treatment for about 3 times longer than DVD to look at an exposure-adjusted way of looking at toxicity. And I think the thrombocytopenia still falls through, although many of us are very familiar with managing thrombocytopenia, and actually the changes in grade 3 and above aren't too significant. The rest of the hematological toxicity is similar. The infection rate, when you adjust, is actually very similar, although there is a slightly higher signal for pneumonia. Now, of course, we are aware of the ocular adverse events due to the keratopathy formed by belantamab mafodotin, and so it's important just to focus on this for a couple of seconds. First thing I would like to point out is the number of ocular events we see in the control arm. And I would like to point out that our myeloma treatments are toxic to the eye. You just have to remember this, because a number of people are complaining of toxicity with daratumumab, Velcade, and dexamethasone, and most of this is caused by bortezomib and dex. But of course, we are seeing this number of ocular toxicities that are being seen with belantamab. Now, just to talk about the next clinical trial, which is DREAMM-8. Now, DREAMM-8 was another prospective phase 3 clinical trial for relapsed and refractory multiple myeloma, and this study was looking at the control arm of PVD, that's pomalidomide, bortezomib, and dexamethasone, again, a very widely used clinical combination for relapsed refractory multiple myeloma, and was being combined with belantamab, pomalidomide, and dexamethasone. And the primary endpoint here is progression-free survival. Now, these results will be presented at ASCO, so I can't share with you the results of this study, but we already know from a press release that the top line demonstrates an extension in time to progression or death with the experimental arm compared to standard of care, and also a favorable trend of overall survival in favor of the belantamab combination. So again, a very exciting trial that we hope to be reading out in the next week or so at ASCO. How about some other combinations in the relapse setting? So this was the DREAMM-6 clinical study, which was looking at belantamab and lenalidomide and dexamethasone. This was a phase 1 study, and you can see here overall response rate was 66.7%, and the majority of these patients were already lenalidomide exposed. But what I wanted to highlight in this study was that we looked at different scheduling ways of delivering belantamab in order to try and reduce that ocular toxicity that you were seeing before. And I'd particularly like to point out this schedule here, which is the 1.9 Q8 dosing. So this is a very convenient way of delivering belantamab every 8 weeks. And what you can see here is in terms of the treatment intensity, okay? So what you see here is that after dose 1, that the highest ability to deliver belantamab on time is given if you give it every 8 weeks. If you try and give belantamab at 2.5 Q4 weekly dosing, then the treatment intensity drops right down to 50%. So you're more likely to give the drug on time, which is what we all like to do as clinicians, and patients like to get their drug on time if you reduce the frequency to Q8 dosing. And we already know that Q8 dosing does not impair the efficacy of this drug because you do maintain the efficacy of this drug. So that's something just to think about moving forward, because personally I will not be giving belantamab VD on a Q3 weekly dosing. I'm not going to be doing that. I'm going to be doing either Q4 or Q8 dosing, and we can talk about this later on in the discussion. Now, we all know that ocular exams is a bit of a burden in terms of patients and is also a drain on healthcare resources. And we need to start to move away from that as we gain further experience with this drug and understand how to manage the ocular toxicity. So we've been doing a bit of work trying to understand patient-reported outcomes in order to assess corneal events and to use this to guide dosing. And this is an example of a patient-reported outcome questionnaire that you can use, you can give to patients, and you can inform the way that you deliver drugs. You're going to start to see some data coming from Evangelos Terpos, who's already using this and has some very interesting data. And in the UK, our academic PROMISE trial will be looking at this in a multi-site fashion, in a randomized way, to demonstrate that you do not need ocular exams and can rely on questionnaires such as this moving forward. Now, Saad has already mentioned the concept of sequencing, and we still need to try and understand how we can use different BCMA-targeted drugs together. What we know from the DREAM2 clinical trial is that soluble BCMA appears to be maintained when patients relapse from belantamab mafodotin. You can see in this box and whisper plots that actually soluble BCMA is maintained, suggesting that you do not, in general, lose BCMA expression. Although I should point out that soluble BCMA is a surrogate marker for actual BCMA expression in the bone marrow, so we do need to learn more about this. But contradictory to this, we know that the results from CARTITUDE-2 demonstrate that if you give an ADC prior to cilta-cel, that the progression-free survival is just 9 months. So we need to try and understand what this means, because this suggests that BCMA expression is maintained, but we're seeing a negative impact upon cilta-cel. However, if the time of the ADC administration is long compared to the CAR T-cell, then you get better results. So I guess what I'm trying to say is that we understand this a little bit better, and I guess we need to discuss this amongst ourselves as to how you best sequence this, and we need to generate better data, because I think the data is conflicting in this current date. The final point I wanted to mention is about infections, and Saad talked a lot about infections and bispecific antibodies. Those of you who use belantamab will know we don't see that same picture, despite it being a powerful BCMA depleting drug. So it can't all be to do with the BCMA depletion. This is some real-world data that we generated from UCL, where we combined the data for belantamab and combined it with our bispecific T-cell engagers. What we see is twofold. The first is that the nadir of IgG is much lower with BCMA antibodies compared to the antibody-drug conjugate. And on the right-hand side, we see a significantly higher infection signal with BCMA bispecifics, 2.2 times higher per person compared to the antibody-drug conjugate. It is particularly bacterial infections, but you can see here a large number of viral infections, particularly respiratory viral infections you're seeing with the bispecific antibodies, which you're simply just not seeing with belantamab mafodotin. And also, just to say that only 2% of patients receive IVIG with belantamab compared to 40% with bispecific antibodies. So a very different picture in terms of antibodies infection signal. And with that, I'd like to conclude and say that the development path with ADCs has been challenging, and many are not, unfortunately, progressing through early development, but I think that the tide is going to change with new technologies. Belantamab does represent the first ADC that has made its way to phase 3 clinical trials. And these new studies, which I've shown you, are hopefully going to move to more wider use of belantamab in these combinations. I do believe that the toxicity profile can be managed, particularly with less frequent dosing. And I do believe that we can also, in the future, replace eye examination with questionnaires and watch this space as we move forward. And we need a lot of work to try and understand the sequencing with bispecific and CAR T cells, because clearly all of these modalities of treatments are very effective in myeloma. We just need to understand how best to use these. Thank you very much for listening.
Thank you very much, Rakesh, and really beautiful talk and summarizing the journey of antibody-drug conjugates, and I think very exciting data about this so-called DREAM7, DREAM8 results. And obviously, although the target is the same, actually, we need all of these agents because the mechanism of action, the safety profile is totally different. So that's really good news. And speaking about the same target, actually, of course, we couldn't skip the cellular therapy and the CAR T cells targeting BCMA. And 2 of them are already approved in Europe and in the US, namely ide-cel, cilta-cel, but there are also a few academic products, the ARI2 from Spain and many others. And Dr. Suzanne Lentzsch has kindly accepted to give us the summary of the state of the art in this field, and then we'll go for the discussion. Thank you, Suzanne.
Mohamad, thank you so much for the kind introduction, and congratulations on the 10th COMy. Really great start with a filled room, even before the official event has started. So let me proceed with anti-BCMA CAR T cells. Here are my disclosures. I would like to start my presentation with an outline of the principle of CAR T cell generation and therapy. You all know that CAR T cell production starts with a collection of the PBMCs for genetic modification, followed by a T cell activation, that's an ex vivo cell processing. The cells will be transduced with a retroviral vector that encodes for the CAR gene, and the T cells will bring into proliferation and then given back to the patient. In between, the patient will receive a lymphodepleting or bridging therapy. Dr. Mohty already mentioned that we have several approvals for CAR T cells, and what you see here is really a very positive development in Europe and in the US, because you can see on the upper part, this is the approval of CAR T cells and bispecifics in Europe, and in the lower part, the approval in the US. And what you appreciate is that ide-cel was approved in Europe and in the US almost at the same time for patients with 4 prior lines of treatment, including IMiDs, a PI, and an anti-CD38 monoclonal antibody. Cilta-cel followed quickly also in Europe and the US. And recently, in March and April, we had the approval of cilta-cel and ide-cel in Europe and in the US, but now we can use it much earlier. You can see that cilta-cel was approved for at least 1 prior line of treatments, also for patients receiving an IMiD and PI, and ide-cel was approved for at least 2 lines of prior treatment, giving us the opportunity to have the CAR T cells much early in the treatment of patients. So the 2 commercially available CAR T cells, ide-cel and cilta-cel, have slightly differences in their structure. You can see that ide-cel has 1 binding domain, whereas cilta-cel has 2 single domain antibodies targeting 2 different epitopes of BCMA, questioning whether this leads to increased efficacy. So let me start to present you the data with ide-cel that led finally to the approval and were presented and published by Dr. Munshi in the New England Journal in 2021. And what you appreciate here is really a dose response curve. You can see that patients receive different dosages with CAR T cells, 150, 300, and 450 million cells. And what you appreciate is that the overall response rate is the highest in patients receiving 450 million cells with a CR of almost 40%. This also led to a different progression-free survival, with the highest in patients receiving 450 million cells. The progression-free survival was 12 months, whereas all patients had a progression-free survival of 8.8 months. The overall survival was 19.4 months, with a median follow-up of 13.3 months. The first data from cilta-cel were very impressive, and I remember the ASH, the data were presented, everybody was in awe and really impressed by the overall response rate of almost 100%. I mean, this is 97.9% with a VGPR of over 90%, the CR of 82%, very impressive data from that trial. And looking for the 27 months progression-free survival rate, you can see that patients who achieved MRD negativity after 12 or 6 months had the best outcome. They had a progression-free survival rate between 70 and 80%. All patients had a progression-free survival rate of over 50%. Looking for the overall survival of all patients, again, 27 months overall survival rate in this study was over 90% in patients who had MRD negativity, and for all patients it was over 70%. At that time point, really stunning data, because remember, those were the heaviest pre-treated patients with 4 prior lines of treatment, and having seen all our triple-class IMiDs, PI, and the CD38. So with a longer follow-up, the data remained very promising, but we didn't see a plateau. What you see here is that after 4 years, patients who had a CR didn't reach the median overall survival, but patients without a CR had still a disappointing outcome with 7.87 months. So based on those promising data, the CARTITUDE-4 study was started. And again, I want to point out that patients were included with 1 prior line of treatment, at most 3 prior lines of treatment. There was a randomization 1-to-1 to either the standard of care, which was pomalidomide, Velcade, Dex, or daratumumab, pomalidomide, and Dex. Or patients were randomized to the treatment, to the CAR T-cell treatment arm with cilta-cel, and patients could receive bridging with the same regimen in the standard of care arm, PVD or DPD. So here you see the overall response rate of the CARTITUDE-4 trial and the MRD negativity. I think what you really appreciate is that the CR is 73% in the cilta-cel arm compared to 22%. You can see the dramatic increase in the complete response rate. Surprisingly, we saw the same number of or even less complete responses in the less heavily pretreated patients. So looking for the MRD negativity and the intention to treat analysis, there was an increase of the MRD negativity from the standard of care arm, 15% to over 60%. And if you look for patients who were evaluable for MRD, it went up from 32% to 87.5%. So looking for the PFS and the PFS by lines of treatment for the patients in the CARTITUDE-4 trial, you appreciate that the standard of care patients had a median progression-free survival of around 12 months, 1 year, but it was not reached at the time of approval for the patients who were treated with cilta-cel. Also, when we look for the prior lines of treatment, there was an increase in the PFS in patients who had only 1 prior line of treatment compared to 2 and 3 prior lines of treatment. But what you also see is that it was even heavier pre-treated patients receiving the CAR T-cells did better than the standard of care patients only receiving 1 prior line of treatment. And cilta-cel was approved earlier this year in the US and also in Europe for patients with relapsed refractory myeloma receiving at least 1 line of treatment. So what about ide-cel that was tested in the KarMMa-3 trial and a randomized trial? Again, I want to point out the main difference is that those patients had 2 to 4 previous lines of treatment, so they were heavier pre-treated, makes it difficult to directly compare cilta-cel and ide-cel in those different randomized trials. And the randomization was also a 2-to-1 randomization with patients in the standard of care regimen having more options such as DPD, DVD, ERD, ixazomib, Revlimid, Dex, carfilzomib, Dex, and also ilotuzumab, pomalidomide, and dexamethasone. Here you can see the overall response rate and the progression-free survival rate. And what you appreciate is looking for the overall response rate and focus on the complete response rate. That went up, sorry for this, that went up from 5% to almost 40% in the entire patient population. But look for the high-risk cytogenetics, the RISS stage 3, also the high tumor burden group, extramedullary plasmacytoma, and the triple-class refractory, all high-risk groups. They all had a significant increase, especially in the complete response rate, showing the benefit for the CAR T cells. Looking for the progression-free survival, again, the standard regimen didn't do very well with 4.4 months. That was, I would say, a disappointing PFS, but ide-cel significantly better with 13.3 months of the progression-free survival. Again, ide-cel was approved also earlier this year in Europe and in the US. So, but bringing those CAR T cells earlier to our treatment has biological consequences. And I think we just have to really discuss with our patients that despite all the excitement that CAR T cells are very potent and the most potent treatment we have right now, that there are potentially side effects. And those biological consequences are based on the mechanism of action. When you infuse the CAR T cells, there's an expansion of the CAR T cells. The binding to the tumor cells releases antigens, and that triggers APC stimulation, also lymphocyte stimulation, and the antigens stimulate macrophages and dendritic cells, leading to a release of cytokines IL-1, IL-6, TNF-alpha, and our CRS. And this is a typical picture of when we expect CRS and the ICANS, the immune effector-associated neurotoxicity. You can see that the CRS occurs pretty early after you infuse the CAR T cells. Later, around day 9-10, we expect also the ICANS, the neurotoxicity. And the ICANS are usually in parallel with the CAR T cell number expansion, which you can also measure in the peripheral blood of the patients. This all is triggered, as you can see, by cytokine storms, by release of IL-1 beta, IL-1, 2, 7, just to mention this, and then later in a second wave, IL-6, 8, 10 interferon gamma, and TNF. So how do we manage CRS? First thing is tocilizumab, and we were very concerned that maybe the treatment of CRS might jeopardize the effect of the drug and really lead to less remission rate. But we have learned, that we really can very generously treat patients with tocilizumab, which is an humanized anti-human IL-6 receptor monoclonal antibody that can be given, and also steroids, which is second line of treatment for CRS, can be given without really jeopardizing the response to CAR T cells. Anakinra is the last resort in case tocilizumab and steroids are not working. It is a neutralizing antibody that binds, decreases the activity of IL-1 alpha and beta by binding to the receptor, and it can give them as a subcutaneous injection. I also want to mention something that's not necessarily on our radar, the macrophage activating syndrome-like manifestations that can follow the BCMA CAR T cells. And those macrophage activation syndrome-likes are characterized by a high level of ferritin, a decrease in fibrinogen, and also an increase of the LDH. And there's a typical pattern that first there's an increase of the CRP followed by the ferritin. There's some discussion whether this might be triggered by infections that precede, the CAR T cell infusion. So the macrophage activation syndrome is a type of secondary hemophagocytic lymphohistiocytosis, and this is triggered, and you all know this very well, by cytokines. And what you see with the red lines is really patients who developed HLH compared to patients who didn't. And you can see the cytokine storm, especially interferon gamma and IL-18, 13, IL-6 are really extremely high levels. So this leads, as I mentioned already, to a high level of ferritin, LDH, but also low levels of fibrinogen. There can be There can occur a coagulopathy, and cytopenias, triglycerides can be high, and hemophagocytosis. Unfortunately, if you have a full-blown HLA, this is associated with a high mortality, and you can see, according to the ferritin value, if it is over 40,000 nanogram per milliliter, this has a mortality of over 50%. It's a very rare event, but again, we have to think about those types of side effects in the earlier lines of treatment for our younger patients to really recognize and treat it early. So that already leads me to the pro and cons. What are the pros for the CAR T cells? High response rates. There's no doubt. Improved PFS, a little bit too early to discuss the overall survival from the CARTITUDE-4 and the KarMMa-3. It can be now used in earlier lines of treatment, and it's a one-and-done approach. Most of our patients report really they felt the best after the CAR T cells, where there was no maintenance and no other treatment for several years. The cons, it's still not curative. A little bit disappointing, but patients unfortunately did not develop a plateau, and many developed resistance to the CAR T cell therapy. We have, and I discussed that CRS and neurotoxicity, there is a lengthy manufacturing process, and some patients cannot get the CAR T cells because we have difficulties bridging them or in the past getting a slot. There's also limited accessibility due to high costs, especially in certain centers, and there might be logistical barriers for patients without a social support, and also only in specialized centers is this drug available. Last but not least, not all the patients can really tolerate the CAR T cells. I think especially the very frail and older patients are not really great candidates for the CAR T cells, but as you have heard from my colleagues, we have other options with the bispecifics and also with the drug conjugates. And with this, I would like to thank my team back in New York, taking care of all the patients so that we can share and discuss our recent approaches. And with this, I think I will give it back to Mohamad. Thank you so much.
Thank you very much, Susan. Also, another beautiful talk, and I'd like to thank all three speakers for really taking the time, and I love this last slide with pro and con, and we can see clearly that this is truly the era of personalized medicine, because with one target tumor antigen, you have 3 drugs, and then one needs to figure out and to play how to use this or this drug, and actually the same target can be used at different time points. So any questions, any comments, any thoughts from the audience in the room? Okay, so maybe I can start while people are getting ready. Today, Susan, and the same question is to Saad and Rakesh. I mean, patients in general are very excited about CAR T cells because of this single shot, you know, and then probably treatment-free interval. But there are many contraindications actually, and not all patients are able to make it. So in your practice, what are the barriers, assuming they are available? I'm not talking about cost, I'm not talking about availability, but they are available. But still, in our experience, even if they are candidate, I'm not able to deliver CAR T cells on time to everybody. So what are the contraindications?
So maybe I start. I always imagine the patient has a CRS, and how would the patient do with CRS? High fever, low blood pressure, oxygen requirements. So I think the frailty is really what I take into account most. And if patients have comorbidities, COPD, for instance, or they have other comorbidities and over 80, you know, that's probably the age where I would be very careful. Then I suggest to give the bispecifics or even the drug conjugates, because we have to take really into account what's the goal of treatment. It's different if somebody is 50 or somebody is 80. An 80-year-old person, what is a life expectancy? what I want to do with my myeloma treatment is that this patient's reaching the expected lifetime. So if I can give that patient 5 more years, that is in a good quality of life. That's my goal. So if I can achieve that with bispecifics, fine. So I'm not really a hero in especially the older patients.
Saad?
Yes, so I agree with Suzanne's comments. I think that they're very pertinent. I think we think about the pace of disease relapse in putting that equation together. We know that CAR-Ts are, we still have finite number of slots on a monthly basis that are assigned to each site. So, the patients have to be in the right disease control in the right window to get apheresed, and then you have to wait for a little period of time. But we're starting to think about these options in light of CAR eligibility or not, and it's not just just the age and frailty piece, but where they are in their disease course and can we deliver it to them effectively in that window.
Rakesh?
So I think that's all correct, and just to throw in the comorbidity piece a little bit, because renal impairment is very common in our myeloma patients, cast nephropathy and drugs, and we have to be careful with fludarabine. And there is some interesting data now coming out using bendamustine or maybe just using cyclophosphamide, and I think we need to understand that better as to how we can deliver lymphodepletion in the face of renal impairment.
Thank you. And I think this issue of renal insufficiency is well taken, because fludarabine can be almost life-threatening in some cases. So at the end of the day, I think you clearly highlighted that, unfortunately, despite our wish to do it, I calculated roughly half of the patients will not be able to make it to CAR T cells for this or this reason. But also we have this issue, and Saad, you alluded to the rapidly progressing disease and the need to bridge to CAR T cells. And here the debate is about the optimal bridging, especially when we have a high tumor burden, extramedullary disease. And I thought maybe drugs like antibody drug conjugates, which have like a sort of a chemo-like mechanism of action, can be useful. Any thoughts on this?
So I think it's certainly a good idea. Historically we've been using, I shouldn't say historically, it's only the last few years, but we have utilized DCEP or pace-based regimens to kind of control the disease and buy us more time in the space. But many groups are already looking at antibody drug conjugate or even bispecifics as potential bridging, whether using the same antigen target or a different antigen target. So I think those are very important questions and would be good strategies to think about.
What are your bridging tricks, Rakesh and Suzanne?
Yeah, so I agree with Saad. I mean, we tend to use chemotherapy as bridging, and it's typically a PACE or a cyclophosphamide-based regimen. But I'm also intrigued about using these novel agents. I think there's some data that's going to be coming out with GPRC5D T-cell engagers as bridging. I think that's going to be interesting. I think with the ADCs, you have to be a little bit careful if you're using it as monotherapy, because the response rate is about 30%. So that may not be particularly effective bridging. So you'd have to use a combination to be able to do that.
Yeah, same here. We have good experience with talquetamab to use as a bridging therapy. Interesting, a lot of patients go already into complete remission before we give them the CAR T cells, which is a kind of problem. Patient asks, do I need that even? Yeah. So, but that's very attractive. You give it for a short time, talquetamab, and you bring down the tumor load, and excellent response rate, and you save the target.
So there's another question and issue I mean has been raised by our virtual audience, is that trying to put on one side the immune therapies where you need the T cells and rather fit and healthy T cells, and on the other hand with antibody drug conjugates where in theory it's independent of the T cells. So how do you view these potential advantages or disadvantages? Because we love immunotherapy, it's like a keywords revolutionary thing, but in myeloma, T cells are not always the fittest. I'd say. What do you think?
So I think even before going to the mechanism of action, BCMA antigen loss is not the most common mechanism of resistance to BCMA therapies. I want to make that point because that means that you would be able to sequence different BCMA targeting therapies in the same patient, whether it's CAR, bispecific, ADCs. I do put ADCs in a different category. So, even with exhausted T cells or someone, who has progressed on CARs or bispecifics, if they have BCMA expression, by all means, I think they can get ADC and vice versa. Very few patients will have that antigen loss. So I do feel that these are two categories that we would be able to sequence effectively.
I just want to comment on the T cells. I think we all learned it really, the hard way, the infection rate in patients receiving the bispecific. I mean, you eradicate the B cells and you also engage the remaining T cells. Patients had infections we never saw in multiple myeloma. So I think we are all aware. But we have that percentage of patients that comes to us already with a history of severe infections and hypogammaglobulinemia, et cetera, et cetera. I think for patients with an extensive history of infections and maybe life-threatening infections, maybe the ADCs are really good where you save the T cells. I would take that into account, and I think belamaf is a great, addition to our armamentarium for those frail patients.
Absolutely. But I think with sequencing, our diagnostics aren't good enough, really, which is the problem. So whilst antigen loss may be rare, we know that there can be mutations in the epitope binding sites when people are treated with BCMA-targeted agents, and we just don't know how to measure for that in routine clinics, and we don't have proper assays for T-cell function either. So unfortunately, we're a bit in the dark when we come to sequencing.
Thank you, Professor San Miguel.
Yeah, I want to continue with belantamab, the ADCs. I think this was a drug that everybody considered was little value. On top of the toxicity, the initial results were rather poor in the comparison with PD. But now you are showing 36 months median PFX. This is similar to the CAR T, to the best CAR T. I'm not going to say anymore.
Any thoughts on this very well taken comment from a giant in the field?
No, I would, agree.
Also, the disclaimer, we can't compare across trials, guys, this.
So, it's a good problem to have, right? So we have very effective therapies. From a pragmatic standpoint, the likelihood of using ADCs or bispecifics for myeloma patients around the world is of higher yield than CAR T-cell therapy. So if you can get the same efficacy with these therapies for a broader population, by all means, I think that is a very welcome thing.
Again, the lower infection risk, you spare the T cells, and also the availability is, really an advantage. A little bit annoying, I have to be honest, is the whole thing with an ophthalmologist. That's sometimes difficult to navigate, especially in the States, and where they don't get any appointments for ophthalmology. But again, that's a minor issue, compared, seeing the response rate and the good side effect profile.
No, I agree. I mean, the results are quite outstanding. I would just like to point out that this wasn't a triple-class refractory population, which is the population that you see with the CAR Ts, though. But clearly, I think an outstanding result and more convenient and more accessible, I think, across the globe than CAR T cells.
So, Suzanne, you alluded to the risk of infections with bispecifics, and there are multiple mechanisms of action. And one of them is that BCMA is also expressed on the normal plasma cells, and then actually you are inhibiting the secretion of immunoglobulins. And Rakesh, you had a nice slide putting side by side, on one hand with belantamab, you have this issue of keratitis, and apparently by modifying the schedule, we can circumvent this. But on the other hand, we have a question which I think is a smart one. If you're targeting BCMA and killing the normal plasma cells, so in theory, you are reducing or inhibiting Ig production irrespective of the drug. So why you don't see more infections with antibody-drug conjugate compared to bispecific? Is it simply because of the T-cell exhaustion rather than the targeting of the plasma cells?
So I think it's T-cell redirection is the problem, because we know that T-cells are very important, particularly with viral surveillance, and their purpose is against virally derived antigens. And when you look at the slide that I showed you, we see a very big difference, particularly in the viral infections between the two. So I think that's predominantly it, but also the amount of plasma cell suppression is different.
Yeah, I think we see typical cells for T-cell loss. Infections, you have more in allogenic transplant, CMV, PGP. It's really amazing, you know, what we suddenly had to, you know, consider as a risk for the reason for the fever, you know, than before. So I think it's clearly, you know, the difference between the ADCs and the bispecifics is, you know, that the T cells that are left are engaged in the anti-tumor response and not available for the antiviral response.
So we're skewing the whole immune response towards.
I think another very important piece is schedule of therapy. With ADCs, you're really spacing out that, you know, BCMA-directed treatment, so you give enough time for the immune recovery to happen. Whereas with bispecifics, you keep on telling those T cells to keep on doing their job, you know, and you know that leads to both a qualitative and quantitative decline in lymphocyte and plasma cell function. I think that does not happen with ADCs.
And the field is moving away from treating until disease progression, and we really think that probably a shorter time until patients are in a CR or limited time is better for the patients compared to the indefinite treatment.
And actually, with less frequent dosing of bispecifics, we are seeing less infections.
IVIG, don't forget, you should mention
And
that.
IVIG.
I think you have summarized it, all of you, very nicely. Actually, we need all of these tools until we have cured all patients. So guys, I need to check whether you've been following carefully, because you need to answer these questions. The post-assessment, otherwise we won't deliver your certificates. So again, the famous QR code, so all of our lives are now run by QR code. Even when I will need to have a coffee, I need to scan my QR code. So question number 1, which of the following options represent a potential advantage of using bispecific for targeting BCMA in relapse refractory? And I think Saad put the answer on one of his slides. So if you're following carefully, you should know what is the answer, A, B, C, or D. Please answer. Are we okay? We're missing some music actually, but anyway. Okay. Well, you know, it's off-the-shelf availability, and actually this is true both for the bispecific and antibody-drug conjugate. And obviously you did great, 90%. The other 9%, guys, I need to see you outside the room, guys. We need to have a sort of a private discussion about your attention during this. Okay, question number 2. Can I have question number 2? Yeah, which of the following options is false regarding belantamab? Belantamab targets BCMA. Please don't get it wrong. Belantamab is an antibody-drug conjugate indicated in relapse refractory multiple myeloma. Belantamab is currently only indicated in the frontline setting. And maybe the semantic is not correct, because Rakesh mentioned that there are subtle differences between the UK, the EU, the US. So let's say belantamab has data in the frontline setting, and A step-up dosing is part of the administration schedule of belantamab. Again, please vote. Okay, wonderful. You got it right. The majority, great. Question number 3, which of the following statement is correct? Toxicity of CAR T cells is difficult to manage in the setting of myeloma. You know, life is difficult in general, but bispecific antibodies can only be developed against BCMA. I hope you heard about GPRC5D, FTRH5, and all of these guys. The optimal sequence of the different immune therapies in myeloma is yet to be established. And patient can never receive bispecific or antibody-drug conjugate. Very, very easy one, come on. Okay, are we voting? Are we fine? Everybody's happy? Okay, the right answer, you got it right. There is still, like, you know, some undisciplined 10% of the guys. Give me your names, and I'll figure it out for the rest of the meeting. I think you did great. Obviously, the $1 billion is about the optimal sequencing, but it looks like we're going to use all of them. The question is whether it's ABC, whether BCA or CBA, or, I don't know, CBA, CAB, etc. So thank you all for your attention. Thank you all for being here very early morning. Thanks to the whole team. Thanks to the faculty. Thanks to all of you across the globe following us. And you deserve a nice coffee break before we start the real true business with the opening of COMy. Thank you.